So welcome everyone. Today we have Rana, one of our PGY5s, joining us, and she's going to be presenting on thromboprophylaxis in high-risk patients with cancer. So,
Dr. Lee, and thank you so much for everyone for joining in. Again, today I'll be talking about thromboprophylaxis in high-risk patients with cancer. So let me start by the objectives. So first of all, I'll be talking a little bit about introduction and background, but I'll talk about risk factors and some landmark trials. I'll be focusing on the AVERT and the Cassini trials, and then I'll just talk a little bit briefly about what we have in our current guidelines. I'm just gonna have to change this here. So let me start by saying that nowadays cancer is an outpatient disease. As it has been known for many years, patients with cancer have a high risk of thrombosis, both arterial and venous, compared to the general population. That can obviously increase risk of morbidity, mortality, and system cost. It is estimated that around 5 to 20% of patients with cancer can develop venous thromboembolism with an annual incidence of 1% per year. With nearly 80% of clots occurring in the outpatient setting, the risk always has to be weighed against the risk of bleeding, obviously, especially that cancer patients have high risk of bleeding, for example, when they're receiving chemotherapy that can induce thrombocytopenia. So in this large study that I have on my slide here, so this was a large population-based cohort study that was published in ASH of 500,000 Danish cancer patients. It was found that the 6-month venous thromboembolism risk for cancer patients was around 12-fold higher than the general population, and even higher, around 23-fold more in cancer patients receiving chemotherapy or targeted therapy. In this study that was done by Khurana et al., they looked into thromboembolism and mortality in patients receiving outpatient chemotherapy in 2007. It was conducted over around 117 community cancer centers in the States. They looked into causes of early mortality in cancer patients initiating chemotherapy. Patients had good performance status, and most of them had an ECOG status of 0 to 1. They were followed for a maximum of 4 cycles to look into the cause of early mortality. And as you can see, the first, I don't know if you guys can see my mouse here. The first leading cause of death was cancer progression, and then the second leading cause of death was basically split between thromboembolism and infection. And in fact, 1 in every 10 deaths were secondary to thromboembolism event. In addition to direct cause of mortality, the occurrence of thromboembolism during chemotherapy in these good performance cancer patients was also associated mortality during chemotherapy. It was found that the chance of dying from thromboembolism events in these patients are around 47 times higher than the general population. VTE also impacts the healthcare system, and in this article that was also conducted by Dr. Khurana and the group in 2013, it was published in Clinical Economics and Outcomes Research. It was found that oncology patients with VTE are 3 times higher in all-cause hospitalization, and they spend 10 days more than what it was expected. And oncology patients with venous thromboembolism had a higher overall cause of inpatient cost. The mean was $21,000 per patient, and the outpatient cost was around $50,000. I'm talking US dollars. And then the total healthcare cost was around $75,000. The mean VTE related costs was $9,247 dollars per patient per year, and then the adjusted mean all-cause cost of venous thromboembolism was around $30,000. There was another article that was published in 2020 in the Cancer Journal. This was another cost-effective analysis involving a hypothetical cohort in the United States. Suggested that the low-dose DOACs were cost-effective for the prevention of venous thromboembolism in ambulatory patients with cancer who started chemotherapy and were at increased risk of VTE, especially with a Corona score of more than 2, with an incremental cost ratio of around $11,000. In Canada, this was a cost analysis that was conducted in Ontario to look at measuring the cost effectiveness of an intervention by considering both its cost and its health outcomes. They basically pulled data from multiple studies, including the AVERT trial, and analyzed different potential scenarios, including patients who received one chemotherapy regimen for 6 months before moving into complete remission, or patients were assumed to be cured of cancer if they survived 5 years from the start of chemotherapy, and then primary thromboprophylaxis using apixaban that was stopped if the first VT or major bleeding event occurred. There were other multiple scenarios. This was like a very complicated study that had a very complicated analytical method. They used, again, they used complicated analytical model to estimate the costs and outcomes associated with apixaban compared to usual care. Results were consistent with the studies or the two previous studies that were done in the States. However, it differs that in Canada, as everyone knows, we have a public funded healthcare system. Therefore, cost and health system usage were reflective of this environment. So results basically showed that apixaban resulted in a lower health system cost. Basically, as you can see here, it basically cost, the cost was like around $8,000 versus $14,000 in usual care, and basically it resulted in lower health system costs by around $700. So as all of us know, there are multiple risk factors that are associated with developing thrombosis. The most important risk factor is cancer-related, including to the type of cancer. As many of you know, the type of cancer most strongly associated with increased risk of thrombus formation is GI, pancreatic and stomach cancers, as well as GU cancers. Cancer histology. Cancer histology was also found to have diagnosis. For example, adenocarcinoma of the lung was associated with more clots than squamous cell, and then high-grade cancer were also associated with more clots. In terms of treatment for cancer, again, including like it can come at many types, like surgery, hospitalization, and immobility, and then the use of chemotherapy, for example, thalidomide and lenalidomide were found to have increased risk of thrombosis formation. Immunotherapy, like bevacizumab, that is commonly used in GI cancers, and then anti-GFR can also increase the risk of clots, and then hormonal therapy, as we all know. As for patient-related traditional risk factor, old age, as we all know, and then sick patients with more comorbidities also tend to form more clots. And then ethnicities, some ethnicities are more prone to get. And then, as we all know, mechanical compression and stasis that can be induced by tumors compression can also increase the risk of clot. And then there's this risk prediction score that I'll talk about in just a second that also contribute to increased risk I'll explore some of these risk factors in more details. In this study that was conducted in 2012, it was also done by Dr. Khurana and the group, and was published in the Cancer Journal. It was shown that pancreatic and stomach cancers were on the top, and followed by colorectal cancer. Those were shown to have the highest risk of venous thromboembolism. Supposed to be for some reason it didn't work, but as we all know what Khurana score is. So basically it's a validated score in predicting venous thromboembolism in selected high-risk patients with cancer, depending on their hemoglobin, white counts, platelets, and then as well as D-dimer if you're using the modified Khurana score. In terms of studies that looked at thromboprophylaxing high-risk cancer patients in the outpatient settings, there are multiple trials done to look into thromboprophylaxing cancer patients with low molecular weight heparin. Some of these studies were done in unselected patients, so both low and high-risk cancer patients were included. Ultimately, these studies were unfavorable just because first of all, there were some, although there were some reduction in the risk of VTE in cancer patients, the number needed to treat in some of these studies were high, and there were more bleeding found in these unselected patients. And obviously there was the high burden of using daily injections. So then some pivotal clinical trial in 2019 was published. There was the publication of the AVERT trial, which is a multi-center randomized placebo-controlled double-blinded clinical trial that was published in NEJM. This trial was had an intention to treat that included around 13 Canadian centers and included around 570 patients that were randomized to apixaban of 2.5 milligrams or twice a day versus placebo. They basically looked at using like placebo versus apixaban in new or recurrent cancer. Patients starting chemotherapy, and instead of using unselected oncology patients, these were patients with a Khurana score, or I should say modified Khurana score of 2 or more, so intermediate or high thrombotic risk based on the prediction score. These patients were followed for around 180 days. The inclusion criteria was basically age of more than 18, newly diagnosed cancer or progression of a known cancer after a previous complete or partial remission. And then they initiated chemotherapy with a planned duration of at least 3 months, and then modified Khurana score of more than 2. They basically excluded patients with increased risk of bleeding, liver disease with coagulopathy, basal cell carcinoma, squamous cell carcinoma, acute leukemias, or MPNs. And then patients who had planned stem cell transplantation, patients who had life expectancy of less than 6 months, patients who had creatinine clearance of less than 30, and then platelet count of less than 50,000. The primary efficacy outcome was the first episode of objectively documented major venous thromboembolism. They basically looked at proximal deep venous thrombosis, or PEs. Within the first 180 days of randomization. Venous thromboembolism was basically defined as symptomatic or incidentally detected proximal DVT of the lower or upper limbs, and any non-fatal symptomatic or incidental PE and any PE-related death. Patients with symptoms of venous thromboembolism during the follow-up period underwent diagnostic imaging for confirmation of the primary outcome. It was also noted that routine ultrasound Dopplers were not done. The primary safety outcome was basically major bleeding as per the ISTH definition, which is overt bleeding with a drop in hemoglobin of more than 2 grams per deciliter, or leading to 2 units of packed RBC transfused, or bleeding in a critical site or bleeding that is contributing to death. Secondary outcomes included all-cause mortality, clinically relevant non-major bleeding, venous thromboembolism during the treatment period, and then major bleeding episodes that was also detected during the treatment period. So table 1 here shows a similar distribution in both arms in terms of age, that was around 60, and weight, that was around 80 kilos, and critical creatinine clearance, that was around 95% or 94% in both arms. Most of cancer in the apixaban arm were lymphoma, and followed by stomach and pancreatic cancers, as well as gynecological cancer. They also included brain cancers, as you can see here, and there were a few colon cancers, and no prostate cancer was involved in the or randomized in the apixaban group. Most patients had a modified Piranha score of 2, and around 22% of patients enrolled in the apixaban arm had a hemoglobin of less than 10. Both arms included mostly patients with good ECOG score of 0 to 1. Around 2.8 to 3% of the population in the AVERT trial had a previous venous thromboembolism. Results basically showed that apixaban did reduce the risk of VTE with an estimate of 4.2% versus 10.2% in the placebo arm, especially in preventing symptomatic pulmonary embolisms. But there was no difference. There was also there was no there was no difference in clinically. I'm so sorry, I'm jumping around. Especially, there was increase in the risk of major bleeding, as you can see here, but there was no difference in clinically relevant non-major bleeds. So basically, in conclusion, prophylactic apixaban reduced the risk of venous thromboembolism in ambulatory cancer patients while increasing major bleeding episodes, with a caveat that distal DVTs were not included and that most of patients had a robust creatinine clearance of more than 50. As for the second trial, the Cassini trial, that was done by Dr. Khurana and the group, and it was also published in NEJM in 2019. This was also a multi-center randomized parallel group phase 3B with an intention to treat trial. There was around 850 patients that were randomized to rivaroxaban 10 milligrams daily versus placebo. Around 140 centers were included in 11 countries, and the duration of follow-up was around 180 days. These patients were enrolled. When they were enrolled to the trial, they had an ultrasound as baseline to rule out pre-existing VTEs, or proximal DVT, I should say. And then they basically were followed at week 8, 16, and then at the end of the date, that was around 180 days, or at the end of the trial intervention. Each trial visit included screening ultrasound of both legs, and so that was how they followed patients. They basically included patients with the age of 18 and more, ambulatory patients with solid tumor or lymphoma, Khorana score of 2 or more, and then patients with an expected survivability of more than 6 months, with a plan to start new systemic regimen within 1 week before or after initiating the trial regimen. They excluded primary brain tumor or known brain metastases, and then ECOG performance status of more than 3, and patients with active bleeding or at risk of bleeding. The primary efficacy endpoint was the composite of objectively confirmed symptomatic or asymptomatic proximal DVT in both the upper and the lower limbs. They also we're looking for incidental PEs and any death from any VTE. Whereas the primary safety endpoint was the occurrence of major bleeding episode as defined by ISTH. Secondary efficacy endpoints included death from any cause, confirmed arterial thromboembolism, and confirmed visceral thromboembolism. Secondary safety endpoints were the percentages of patients with ISTH defined clinically relevant non-major bleeding or minor bleeding and or any bleeding during the intervention period. Table 1 here again shows that around 50% of patients were male, and most of them were Caucasian with a Khorana score of 2 or more. Previous VTE was mainly found in the rivaroxaban group with around 3.1% versus 0.5% in the placebo arm. Most cancers were again pancreatic cancers, gastric or gastroesophageal junctional cancers, and then lung cancers. I'll note that around half of patients did not take the medication for the full 6 months, around 50% of the placebo arm, and around 44% of patients in the rivaroxaban arm did not take their medications. And so if we look at the primary outcome results here, VTE occurred at around 8% in the placebo arm and went down a bit to 6% in the rivaroxaban arm, and this reduction was not statistically significant. And it was explained by the group who did the study that it was partially because VTE occurred around 39% of patients who actually stopped the medication. It was shown, however, that while on the treatment period, it was shown that VTE occurred around 6.4% in the placebo arm and 2.6% in the rivaroxaban arm with statistically significant p-value. It is also important that the risk of VTE-related death was not changed. And then as for the primary safety outcome, major bleeding was not an issue without clinical significance, with 1% in the placebo arm and around 2% in the rivaroxaban arm. So in conclusion, low-dose rivaroxaban did not result in a statistically significant reduction in incidence of thromboembolism at 180 days when compared to placebo, with the caveat that there was a statistically significant reduction in the number of VTE in the rivaroxaban arm during the treatment period. So how is this reflected in our guidelines? The most recent ASCO guidelines basically suggest that routine pharmacologic thromboprophylaxis should not be offered to all our patients with cancer or all outpatients with cancer. And then high-risk outpatients with cancer, for example, Khorana score of 2 or higher, or starting on a new systemic chemotherapy regimen may be offered thromboprophylaxis with a DOAC or low molecular weight heparin, provided that there are no risk of bleeding and no drug interaction. There should be consideration of such therapy should be accompanied by discussion with the patients about the relative benefits and harms and drug costs, as well as the duration of prophylaxis in the setting. And then patients with multiple myeloma receiving thalidomide and lenalidomide regimens with chemotherapy and or dexamethasone should be offered pharmacologic thromboprophylaxis with either aspirin or molecular weight heparin for lower risk patients and low molecular weight heparin for higher risk patients. All I have for today. Thank you so much for joining.